I can't even begin to tell you what an honor and a privilege it is to be the keynote speaker today and to talk to you about my research. About 15 or so years ago, there was a young assistant professor at UCSF who had an idea for a far-out research project, the kind of research project for which it was impossible to get any pilot funding, and which all of the senior mentors that she went and talked to said, "You're crazy, don't waste your time with this is never going to work out." Well, guess who was willing to invest some seed money in it? They're sitting right there. And with this modest amount of an investment, I think it was on the order of that first grant from the Staglin Family Foundation, it was about $15,000, this was before IMRO, and with the intrepid volunteerism of Brandon Staglin, who actually came and was one of the pilot subjects and who gave us really useful feedback as we went along. We were able to complete a study, and now about 15 years later, that $15,000 has translated into an active research laboratory. I'm that assistant professor, now a full professor. We have 6 NIMH-funded projects going on in 3 continents. And we have about $1 million in research funding coming in every year. So again, it's my privilege to tell you about the story of that work. So here's my official title, but that's much too long of a title for a hot day like today. This is the title we're going to focus on, which is Rewiring the Brain, New Science that has allowed us to think about ways we can rewire the brain, and new tools that allow us to do that. So I have some financial disclosures to make. I would just like to put them up here, which I'm going to be talking about some forms of software that have been either given to me to use for free, or I'm a paid consultant on one of the companies that has a financial investment in this kind of software, and I'm also a consultant to several other private companies. So, you all know about the incredible scientific advances that have been made. You all have witnessed the research, some of you have funded the research, and yet there's still a sobering fact that remains today, which is really, when you stop and think about it, the current tools that we have available to treat psychiatric illness are no different than they were half a century ago. What do we have when we have a psychiatric illness? We have some troubling symptoms. It might be mood symptoms, it might be hallucinations, and we have maladaptive behavior. The person finds it hard to get up and go to work, or they feel frightened, paranoid of people. What do we have so far to treat these? Well, we had these same tools 50 years ago. We have medications for the troubling symptoms, and we have some kind of psychotherapy or psychosocial rehabilitation for the behavior, so people can learn more adaptive behavior, talk about it, practice it. Neither of these treatments, and again, these are really still the only treatments we have, neither of these treatments are specifically targeting what we now know from the advances in neuroscience to be the fundamental underpinnings of the causes of psychiatric illness, which is neural network dysfunction in the brain. We know that the brain essentially functions because of the complex integration among information processing in innumerable interacting neural networks, brain cell networks. And that is what gives rise to our mental functions, and when they go awry, that is what gives rise to psychiatric disorders. None of our treatments are targeting those fundamental aspects of brain function which are at the core of what causes psychiatric illness. How do we treat that? Well, I'm going to give you some ideas about how to treat it, but first we're going to become a London taxi driver. We're all going to become a London taxi driver here. So what has to happen if you're going to become a London taxi driver? Well, you have to like to drive, you have to learn to drive. I might add, you have to learn to drive on what we would call the wrong side. You have to like to drive these funky looking kind of cars. They're black, they're sort of odd looking. But more importantly, you have to learn that. So when you become a London taxi driver, you have to study something which is called the book, which has detailed maps of central London, and you have to memorize it. And you have to take an exam in which you can show that you know how to get from any point A to any point B, taking the shortest route and the most efficient route. And that's what you have to do to become a London taxi driver. Well, not too long ago, a really kind of clever group of researchers in Great Britain decided they would study what happens in the brain of London taxi drivers. And what they found is that those people who are studying to become taxi drivers and who undergo this long process of learning all this spatial navigation show changes in their brain. A structure in their brain called the hippocampus, and they have some images here, actually changes in size over the period of time that someone becomes an experienced taxi driver. This was a demonstration that the brain changes in response to its experiences and its learning. It changes its structure. And this is just to give you sort of more global perspective. The hippocampus is a structure in your brain that's important for memory, for learning, for spatial navigation. And this structure in the brain had changed from learning how to become this expert in this complex spatial navigation. So my take-home message to you today is really kind of brain science 101, which is the importance of neural networks in thinking about human behavior and psychiatric illness, and also the importance of neural plasticity. So neural networks, what are those? Neural networks, as I just mentioned earlier, are the way the brain cells connect together, like a wiring diagram, if you will, to allow the brain to carry out its information processing, really actions, and allows us to behave. Neural plasticity, or brain plasticity, refers to the fact that these networks have the capacity to change. Indeed, it is because they change that allows us to be who we are, to learn the things we learn, to adapt to our environment, to respond to the events that are happening around us. It's these brain networks, the way they interact, and the fact that they're plastic that allows us to think, to feel, to sense, to make decisions, to dream, to think about the past, to plan for the future, to get angry, to fall in love, to create great works of art, to create great works of behave in ways that also can be destructive as well. So that's Brain Science 101 for you. So healthy, adaptive human behavior requires the coordinated interaction of these brain information processing systems, these neural networks. I've just put up a cartoon for you here to see if I can give you a flavor. And this is just scratching the surface of the different complex information processing tasks that our brain has to do in a simple everyday encounter. So remember, this is a cartoon. It's more to give you a flavor or a feel to think about how complicated it is that what our brains must do. So you're walking down the street and you see someone, hey, Sophia, the person might wave at you. So what happens first? Your brain registers sensory information. It hears the sound. The sound gets registered in the parts of the brain that process sound. It sees a face. That information gets registered in the parts of the brain that process visual information and then get fed forward and is being processed in the parts that process facial information. So that's happening very, very quickly. But at the same time, those regions are interacting with your frontal parts of your brain. And the frontal parts of your brain is the part of your brain that holds context online, that you're walking down the street, that it's a busy street, but maybe you don't expect to run into someone you know, but there's someone waving at you. So perhaps you should be paying attention to their face and voice because they look like they think they know who you are. It looks like a friendly person. These contextual pieces are being, these sort of comparing, predicting, making sense, creating this context is what your frontal cortex is doing. These regions at the same time are interacting with your hippocampal and memory systems. The face, the voice, the sensory information is being integrated. It's being put into a context that the frontal cortex is giving to it. It's being compared to past information you have. Associations to that information are coming online. And what you know already is kind of being brought to be used in the present moment. So perhaps now you start to say, oh, this is somebody who looks familiar to me. I met her at my cousin's wedding. We had a great time. I remember we had a great chat, and it's Susan. So again, a very simplified diagram of the many, many complicated operations that your brain has to do for this very simple event. Now, one thing we know is that in psychiatric illnesses, and the data on this is beginning to sort of really accumulate in the last few years, is that in psychiatric illnesses, there's dysfunction in these interacting neural systems, these interacting neural networks. For example, in depression and post-traumatic stress, these neural networks are highly tuned to negative information in the environment. It's almost like that's what they're preferentially seizing on or attending to, and it's almost as if those neural systems are filtering out positive information. And so the person who's prone to depression or who's in a depression, as they're moving through their world, their neural networks have this bias towards the negative information, even at a level below awareness. In schizophrenia, we see something slightly different, which is we see that the neural networks are not interacting properly and smoothly together, so that as different parts of the brain have to take on and make, in a sense, process different kinds of information and then integrate it and coordinate it, in schizophrenia, that's not happening smoothly. So what you can start to imagine is that in psychiatric illnesses, what we're having is distortions in how these neural systems interact, and that is going to affect what we see in the world, what we see as behavior. It's going to affect thoughts, emotions, decisions, actions. So again, let's see if we can come up with a cartoon to try and illustrate this. So there's the same event. You're walking down the street. Hey, Sophia, someone says hey to you. So now let's say we've got a sensory cortex which is not registering that information with very good fidelity. And we know, for example, that happens in schizophrenia and perhaps in other disorders as well, such as post-traumatic stress disorder. So that visual information and that verbal information, the person's face, their voice, it's getting registered in a slightly noisy fashion. There's static in the system. That noisy information is being fed forward to a frontal cortex that itself perhaps has some biases, that doesn't hold on to context very well, or that has a bias to only see or to preferentially give processing capacity to information that has a negative tilt to it. So now instead of paying attention to the fact that the person was waving to you, this brain is more seeing this person as being somehow standoffish or not approachable. This is interacting with a memory system which may have anxious or fearful memories related to this negative information. There's some sense of danger or catastrophe when they see a person looking like what they think might be hostile. For this brain, the conclusion is this person's trying to accost me. And again, what you have is you've got these multiple distortions that are happening at different levels of information processing in the brain and leading, in a sense, to a catastrophic set of representations that then guide behavior in a maladaptive way. So this is just an example from our own lab, and I don't want to belabor the point in terms of giving you a lot of sort of geeky data, but this is an example of in schizophrenia where the auditory regions of the brain, which handle verbal information and auditory information, are not interacting smoothly with the frontal regions of the brain during simple listening tasks. And this is causing problems then for the person to be able to engage in accurate memory, memory for auditory and verbal information. And then we see that leads to problems with functioning in the real world. And so this is just an example. We have what a healthy comparison subject's brain activation levels would look like when they were hearing a simple syllable. That's in blue. A person with schizophrenia, it's lowered. There's noise, there's static. It's not as clear of a signal in their auditory cortex, this part of the brain which handles auditory information. At the same time, the frontal regions of the brain, which are also involved in this task because they're holding the context of the task online. We have here healthy subjects. We have here people with schizophrenia on the bottom. And we see that, again, there's not as much activation in this region of the brain. So what we have is the picture here with a simple auditory information task, auditory listening task, that the regions of the brain that need to be talking to each other, the auditory sensory processing regions, the frontal regions that give context, are lower in activation, and they're not, in a sense, I haven't shown you those data, but they're not talking to each other, they're not integrated. And the more we see this problem in schizophrenia, the more this person will have trouble with memory and other kinds of auditory tasks and with functioning in the real world. So the idea behind taking this approach of okay, neural systems aren't working, neural networks aren't working, how can we target them to improve their functioning, and how will that help us help our patients? So it's the idea that the brain is like a muscle, use it or lose it. And we're going to try to think how we can use what we know are the inherent plasticity mechanisms in the brain, and we're going to try and improve these dysfunctional neural networks. And the idea is that if we can get brain function to be acting in a more smoothly coordinated fashion, the speed and the accuracy of information processing in the brain can be improved, the normal neural network functioning can be improved, more integration among neural networks, This will improve cognitive function in the brain. Cognitive function is just a big word for thinking and feeling and decision-making, memory, attention, and then we should get better real-life outcomes in terms of work, social symptoms, mood, and the like. And so I'd like to give you an example of such an approach. And this was a neural network training study that we did at the San Francisco VA that was based on the pilot study that Brandon participated in and that the Staglins funded. And this was a randomized controlled trial of this kind of an approach in people with schizophrenia. And the idea behind this approach is that the core features of schizophrenia are not just the visible symptoms. And again, I hope what you take away from this is that when we think about psychiatric illness, we have to think about much more than just the symptoms that we see as people are suffering and as they go through their lives. So, for example, in schizophrenia, we know there are positive symptoms, the hallucinations and the delusions. We have medications for those. We know there are negative symptoms, decreased motivation. Talking therapy can be very useful for that. But we also know there's cognitive dysfunction. I just showed you an example of it, of how people with schizophrenia, the parts of the brain that have to work smoothly and activate and integrate for simple listening tasks are not doing that. That's an example of the cognitive dysfunction, which in a sense can also be thought of as neural network dysfunction. So that's the underlying principle here. And what we're going to do is we're going to take something that's called an experimental medicine approach. So I'm going to ask you to bear with me. This is a little bit geeky, but it's for also the scientists in the room who are all either taking this approach or thinking about it. And the idea here is we have this hypothesis, right? This prediction, which is that neural network inefficiency during simple listening, auditory task performance, it's a feature of schizophrenia. It's something we see over and over again, and it's associated with cognitive dysfunction. It really makes it hard for the brain to perform its proper sort of thinking and processing tasks, and it leads to problems for individuals with schizophrenia. And so the idea is that if we can improve this, if we can figure out a way to get these neural networks to be operating more efficiently, we'll see clinical improvement. People will actually be able to do better in their real world. So we're going to come up with an intervention that's designed to do that. So what makes it experimental medicine? We're going to investigate our patients before they do the intervention, not just in terms of their symptoms and you know, how many hallucinations they're having, how they feel, but we're also going to investigate their actual brain functioning. We're going to look at how the brain activation patterns are happening or not happening. We're going to see if we're actually going to be able to target them. And we're going to examine it after we do the intervention. And if our idea, our hunch is correct, we'll see those brain systems working better after the intervention, and we'll see people behave, you know, their actual behavior and clinical symptoms will feel better as well. Now, for those of you who are sort of thinking a little bit more deeply about these principles, as I'm telling you about them, a couple of interesting ideas start to pop out. And again, I just want to digress for a moment because I think they have important implications for future research. The first interesting implication is that these core deficits, if you will, in neural network function that we see in many psychiatric illnesses, certainly in schizophrenia, the evidence there is good, may actually be risk factors. In other words, we see these neural network inefficiencies in these auditory processing systems and in other systems in people before they have their first episode of schizophrenia. It's a risk factor. It's a vulnerability factor. So what idea does that give you? Well, if our intervention is going to be pretty good, or hopefully somewhat good, at targeting these systems, we may be looking at something that can be used as a vaccine, right? We may be looking at an intervention that can be given to young people either before they've had that first psychotic episode, but they're showing these neural system vulnerabilities, or right at the first episode with the idea that we're going to really work hard to improve those impaired neural systems right away. So that's the first interesting idea I want you to hold on to. The next interesting idea, and I'm a little hesitant to put it up because I'm speaking in front of many esteemed colleagues whose work I admire greatly, who do work in the molecular and genetic fields, which is advancing at a very exciting pace. But basically, I don't really care. I don't really care about molecules, and I don't really care about genes. Now, I'm saying this to be a little dramatic because I do think that as we understand more of the specific molecular and genetic mechanisms of specific forms of the illness, it's going to allow us to combine that knowledge with these kinds of approaches and make the results even better. But it almost doesn't matter whether you have X form of schizophrenia with X combination of genes or Y form of schizophrenia with Y form of genes. What we are trying to improve or target is the final common pathway in neural network dysfunction that we know is common across all people who have schizophrenia. So now you're going to be one of my subjects before I tell you about some of the studies we've done. So you've come to the lab, you're excited by this project, you're going to participate, I sit you down and I have you do a couple of tasks. So the rabbit ate the carrot. Good. The sailor sailed the sea. You don't have to make up anything up there. I just want you to read it. The dog chased the cat. Great. The storm destroyed the house. Okay, so you've read those sentences. That's great. Now you go on. We interview you. We take blood. We talk to you for hours and hours. We find out what your symptoms you're having and so forth. All right. Here's the study design. We have healthy comparison participants, and we have individuals with schizophrenia. We randomly assign the people who have schizophrenia to this targeted cognitive training of their auditory neural networks, the parts of the brain that have to be employed, the neural networks that have to be employed when you process auditory or information, listening information. And then we have a control group who plays computer games because we want both groups to be on the computer and coming to the lab and meeting the laboratory personnel and getting paid for participation equally. We want to make sure that any improvements we see are due to the cognitive training and not to being on a computer or coming to the lab or being in a study. We have healthy participants do some of the assessments so we can have normative data so we know how do healthy people perform, how do people with schizophrenia perform. And then we do cognition and brain imaging, and we do that at the 2 time points. And then last but not least, we bring people back in 6 months later because the idea is we might do something that might be helping brain networks work more efficiently, but it's unlikely that they're going to experience sudden changes after a study that's only lasted a couple of months in their world, in their functioning. It's going to take some time, right? As the brain is working more efficiently, it's going to take a little time for that to translate. So let's see if this is a demo of one of the exercises. So let me tell you what it's going to, you're going to be hearing 2 sound sweeps that will come up. And they'll either be sounding like they go up, like doot, or they'll be sounding like they're sound sweeps that go down. And you have to listen to these sound sweeps, and you have to tell me, is it up, 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 down, 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 up? And we're going to just demo what this is. This is a form of training. So what you'll notice when we go through it, if you want, is you'll see that the sound sweeps are starting at a certain separation in time and are being presented for a certain duration. And as you get better at it, it'll get faster. It'll get a little bit harder. So we're not getting... Okay, what was that? Down, down. Up, up, good. Down, up, good. You're doing well. So you see how it was getting a little bit faster, right? Now, this exercise will start with around 400 to 600 milliseconds of separation. And if you have a healthy and intact auditory processing system, you'll be able to train reasonably quickly to very, very short durations and short intervals, on the order of about 40 to 60 milliseconds. It's almost, if you're untrained, it's almost indiscernible. You can't tell the difference between the two. People with schizophrenia, when they start doing this exercise, typically need almost a second to be able to do the task. And most of them will have difficulty getting down to those really, really fast levels, although some people with enough training can get there. What does this tell you? It tells you their auditory processing system is less efficient and needs to be trained much more intensively and slowly to get to a place where people without schizophrenia can get pretty quickly. What you'll notice about this form of training is it's teaching the brain to be a really good listener, to register auditory information quickly and accurately and to make distinctions between sounds. This is one of 6 exercises focusing on auditory and verbal systems that we gave. And we did this for about 50 hours, and we did this in our group of schizophrenia participants compared to the people doing the computer games. And what did we find? At the end of the 50 hours of training, we brought people in for some neuropsychological testing, and we just wanted to see how their cognition was doing. Cognition, again, just means things like attention and memory and learning and problem solving. And so I want you to look at this bar graph. Again, I'm not going to sort of bog you down with too many details. Blue is the people who got the targeted cognitive training. Magenta, the people who got the computer games. 0 means no change from before the study. Above 0 means there was a positive change or improvement in this measured domain. Below 0 means there was a worsening. The first thing people notice is that the computer game subjects got worse on verbal learning and memory. We've seen this in a couple of other groups. I'm just going to say parenthetically that we believe this is when people with schizophrenia who already have some difficulties with verbal and auditory information processing are playing visual commercial computer games for 50 hours, it pulls away from those neural systems, and when they have to do a verbal memory task the second time around, they're a little bit worse. This goes away, they come back to their baseline when they stop those computer games for a couple of months. But what you'll see is we see improvement in the targeted cognitive training group across a number of domains, and particularly in domains that have to do with verbal functioning, that's verbal working memory and verbal learning and memory, and their general cognition, which is a summary score, has also made significant gains. But what about their brain, right? Okay, so they're doing better on these pencil and paper tasks. What does this mean in terms of their brain systems? Have they changed? And ultimately, what does this mean in terms of how they can perform in the real world? So we did some experiments which are called magnetoencephalography experiments. They're a way of measuring brain electrical activity by measuring changes in magnetic field on the scalp. And again, I'm not bogging you down with any details here. It's just to show you that it looks like you're in a giant hairdryer when you do it. And as you'll recall, we had talked about the abnormal patterns that we see at baseline. The auditory part of the brain and the frontal part of the brain are decreased in their activation. And what we see after training, and this is just kind of some raw data, which again, I just want to show you sort of an illustration. This is over time. This is starting at 0 seconds as a syllable is being played, a first syllable and then a second syllable. This is the auditory cortex of the brain here. This is the frontal cortex of the brain. This is the image in schizophrenia after training, subtracting out baseline. So this means these are the parts of the brain that are now more active than they were. And so what we see is now activation is coming online in these frontal and auditory cortical regions, indicating that the parts of the brain that are normally used for this simple listening task are now showing more activation. And we also have some evidence that these two regions are now talking to each other in the way they need to talk to each other. We don't see this pattern of change in people who did the computer games. There's nothing, right? No changes in activation anywhere in the brain in relationship to this listening task. What's more interesting is when we start to inquire about what do these changes mean, and we look at what does some of this increased activation in this very anterior part of prefrontal cortex, or this part of the prefrontal cortex, the frontal lobe of the brain, increased activation in those regions are translating with changes that we see 6 months later. So that people who show changes in this activation pattern in this frontal region show more improvement in verbal learning and memory 6 months later. They also show better negative symptoms 6 months later. So the idea that we've changed these frontal regions of the brain to act in a more coordinated fashion, and that's translating to some gains in their functioning as we follow them over time. What happens if we increase the dose and the breadth of training? And we give now, instead of 50 hours, we give 80 hours, and we combine a couple of different forms of training, not just the auditory system, but now we're going to train the visual system, and we're going to train certain aspects of social cognition or face processing that we also know it can be impaired in schizophrenia. Okay, you were one of my subjects. Now I'm going to ask you, I show you this, you're in the scanner actually now. I want you to tell me whether the second word is one you had made up before or if it's one I had shown to you. Dog, cat? You made it up? Okay. Storm house? Showed it to you. Rabbit, carrot? Made it up. Sailor sea? Okay. Was that a hard task? No, not really. This task is sometimes referred to as reality monitoring. It's the ability to distinguish between something you generated inside of yourself, a word you made up, or something that happened to you, a word that was shown to you. What we did is we did a reality monitoring task in the scanner, and people were asked the question, did I make up that second word or did I read it? And we looked at brain activation patterns as they made this decision. Now you have to remember, nothing about the training we gave was working on reality monitoring. The training was just focusing on fairly elemental aspects of auditory processing, visual processing, and social cognition processing, faces and emotions and faces and the like. And yet, with this fairly complex reality monitoring task, we saw some interesting findings. So, at baseline, before they do the training, people with schizophrenia have trouble doing this task. So when you look at the number of items that they make up themselves that they get correct, it's significantly lower. They're in magenta here compared to participants without schizophrenia. And when you look at the brain activation patterns, in the healthy participants, we see these normal frontal brain activation. The brain is cut this way. This is the front part of the brain here. But in people with schizophrenia, when they're doing this same task before they do training, they don't activate these frontal regions. We see activation, abnormal kind of activation in these posterior regions. After the training, when they do this same task, we see some changes. And what we see is now frontal regions are showing activation during the task. Behavioral performance has improved. I didn't show you these data, but people are doing the task better. And not only that, but the amount of activation in the frontal lobes is correlated with the performance on the task. So those people who are showing more activation in the frontal regions of the brain are the ones who are making improvement on the task or doing better on the task or best on the task. More interestingly to us, or more excitingly, is that there's a relationship between the signal in the prefrontal cortex and social functioning 6 months later. So when we bring people back 6 months later and see how are they doing in terms of their social functioning, those who are doing better are those who had more of the signal, more of that activation in the frontal regions of their brain. All right, that's very promising, but what about this idea that I mentioned before of a potential vaccine? I think, as many of you know, if we aim to prevent mental illnesses, we have to find ways to identify and intervene and restore neural network functioning before the diagnosis actually happens. Because by the time the diagnosis happens, there has been dysfunction in these key systems in the brain. Unfortunately, for many people in this country, it's a long time between diagnosis and intervention, let alone early detection and intervention. So I just want to briefly highlight that we have a couple of studies going on. One is with ultra-high-risk participants. These are adolescents, average age of around 18, who have not yet had a first episode of schizophrenia, but who are showing ultra-high-risk clinical signs and symptoms. Many of you may be familiar with that concept. The Staglins have been seminal in funding research in this area. These are people who are beginning to have some symptoms of psychosis or are beginning to look like a psychotic episode might be imminent. And what we show here, again, are in cognitive function, below 0 is poor, above 0 is better than normal. In brown are healthy age-matched subjects. In white are how these people who are ultra-high risk do at baseline. In red is how they do after training. You can see that their cognitive functioning is improving, in some cases to the level of healthy age-matched participants after they do the training. Now, the important piece about this study is that this training is being done on laptops at home. This is mobile technology where people take the laptops and do the cognitive training on their own at home. We've done a similar study in people with first episode schizophrenia. These people are on average 20 years old. They've had their first episode. They're within the first few years of illness. And again, we see these improvements in cognition across a number of domains, perhaps more generalization. And we see that decrement in verbal learning and memory in people who did the computer games, the CG group. But we're seeing, again, these promising results to young people who are about 20 years old when they do the training on laptops that they do at home on their own schedule. And also early data that's unpublished, which we find is very reason for optimism, is that the computer games control group, if we look at positive symptoms at baseline, after training, and at 6-month follow-up, you can see that there is a worsening, or I should say maybe a plateauing of their positive symptoms. That's the group in green. Here, lower is better, whereas the active training group, when we look at them 6 months, at 6-month follow-up, their positive symptoms are improved. And both groups are getting the same kind of medications and clinical care and psychotherapy and so on. So this is what we know so far. I've just summarized it here for you, and then I'll take a few minutes and we'll talk about our future directions. We see that we can improve cognitive performance and drive biological changes. We can improve impaired neural network operations in people with schizophrenia. We can increase these frontal activation patterns in the brain, and that's related to real-world improvement. And we see some similar improvements in young people very early in the course of illness, using mobile devices, perhaps indicating that we can generate some long-term protective effects. We don't know yet. We have to follow people for a period of time to see how their course will be over time. Of course, I make this sound, cutting-edge neuroscience. The fact is this field is kind of here on the left side. We know that it's good to pump iron, that's going to be good for your muscles. We have so much more research to do before we can design the really sophisticated kinds of interventions for neural systems that we know are going to be necessary. And yet, there are a number of promising next steps which are underway, targeting other disorders. I've listed a few of them here, some going on in my lab, some going on in the lab of colleagues. Targeting other neural networks, some that are involved, for example, in impulsivity or more of the social cognition, which is so important in autism. Improving the fun factor. I mean, you did that exercise with me, but was it super fun? Not really. Making use of mobile technology in new and innovative ways, and of course combining with new developments in medications, neuromodulation, such as brain stimulation techniques, and virtual reality. Those of you who follow the prestigious scientific journal Nature know that just this Thursday, our colleague at UCSF, Adam Gazzaley, had a cover on Nature. That's that's just below winning the Nobel Prize. The title says Game Changer. In this, Adam reported the behavioral and neural system effects of a video game that was actually a set of cognitive exercises, analogous to what I showed you, but that was focusing on interference and distractibility, which is something that gets worse as people that get older. And he showed that he was able to bring older adult participants in their 60s and above to the levels of performance of people in their early 20s through this form of training. And he was able to show some of the changes, again, in frontal activation that correlates with these improvements. So this is an area of research whose time has come. Adam and I, along with a junior colleague, Mor Nahum, have worked on bringing together cognitive scientists with experts in entertainment software and interactive neurotechnology. We've had 2 meetings of this society. Again, the Staglins have been generous in supporting the meeting with some excellent wine at the poster sessions. And the idea here is to see if we can draw upon the expertise of people who have developed these interactive softwares to develop therapeutic tools. And another next step is increased gamification. And Adam has been, Gazzaley at UCSF actually has co-founded a company which has taken this pretty boring multitasking training that he published in Nature and made it into this jazzy, 3-dimensional, flying through the air, music playing, kind of a real video game. And they have some trials underway with that. And of course, another obvious next step is mobile technology. We have studies underway where people don't even actually come into the lab, but participate in cognitive training remotely. We're also doing remote assessments with participants. But this is not just limited to the Bay Area. We have some pilot projects in Chile and Brazil, in a public hospital in South Africa, an extremely underfunded and under-resourced place that nonetheless has managed to get some computers and some internet access in different parts of this country. So we really see this as a technology that can not only drive the kinds of neural system changes we are interested in driving in serious mental illness, but potentially also reach patients and populations that are underserved and under-resourced. So, the past, unfortunately, for psychiatric illnesses and treatments for psychiatric illness has been fraught with stigma. often with misinformation, often with the idea that the person with psychiatric illness has to be treated over there or has to come to my office. I'm the expert. I'm going to help this person with these troubling symptoms. But we're really at a place where we're going to break down those walls, right? And I think we're looking at a new era in which a new set of treatment tools are under development. There are FDA trials with these kinds of treatment tools in which people will be able to, in a sense, do the treatments at home on their own schedule, perhaps interacting remotely with a clinician, and also networking socially with other people involved in this kind of intervention, creating a community, perhaps even a global community that's involved in recovery and in leading fulfilling and maximally satisfying lives. So I thank you for your attention, and I thank you for funding our research.